Good afternoon, everyone. We're going to go ahead and get started because it's just a little bit after 12. Welcome to the Fairbanks Ethics Lecture Series. I'm Susan Hickman. I'm a professor in the IU School of Nursing, and I co-direct the ReSPECT Center, the Research in Palliative and End-of-Life Communication and Training Center. This is an IUPUI signature center, which is focused on promoting research and collaboration in palliative and end-of-life care, particularly with a focus on communication. And I co-direct that center actually with Dr. Greg Sachs, who is here with us today, and then Dr. Joan Haase from the IU School of Nursing as well. We are really delighted to be collaborating with the Fairbanks Center for Medical Ethics to present this new lecture today with our visiting scholar. I have a few housekeeping items that I've been asked to attend to before we begin, and then I'll introduce our speaker and let her take over. So first, please make sure that you signed in at the tables that are outside the doors. This helps us track attendance and will help ensure that you receive continuing education credits for your attendance today. Additionally, as a reminder, there is no food or drink allowed in the Riley Outpatient Auditorium, which again, our apologies, this is right over lunch, but unfortunately we aren't allowed to have food in here. This lecture is being broadcast and recorded today. So I want to also thank those who are at our broadcast sites, who are joining us at IU Health Ball Memorial, IU Health West, IU Health Blackford, IU Health North, and IU Health Arnett. Please silence all of your electronic devices. If you do receive a phone call that you need to take, please leave the auditorium to return all those calls. Additionally, our speaker today has reported no relevant financial conflicts of interest to disclose. And our speaker is Dr. Rebecca Sudore, who's a geriatrician and palliative medicine physician, as well as a clinician investigator from the University of California, San Francisco, and the San Francisco VA. She also directs the Innovation Center for Action-Oriented Research, iCare, in Aging and Palliative Care, and the Vulnerable Populations for Aging Research Core of the NIA-funded Pepper Center. Dr. Sudore conducts research to improve advanced care planning and medical decision-making for diverse, vulnerable older adults. To this end, she's designed, tested, and disseminated innovative patient-centered tools, including easy-to-read advanced directives in over 10 languages, and an interactive advanced care planning website called Prepare. I have had the privilege and pleasure of working with Dr. Sudore over the last 4 years, and greatly respect the work that she does. It's very careful, thoughtful, methodical, and innovative. And also, she is, on top of all that, a delightful person to work with, and all wrapped up in an incredibly smart researcher. So I'm really delighted to have her here today to join us, and I'm going to turn the floor over to Rebecca. So welcome, Rebecca.
I think that's maybe the nicest introduction that anybody's ever given me. So thank you so much, Susan, and it's really a pleasure to be here today. I'm hoping, as I go along and as I'm talking, if people have comments or questions, feel free to ask them, and I'm hoping that we'll have time sort of at the end if we have time for discussion. So, I think when I think about advanced care planning and what I'm going to talk about today, really, it's sort of all about stories. So it's all about patient stories. I'll be telling you stories from things that we've heard in our focus groups from patients and their loved ones. And when I think about stories, it's the idea of how do we preserve our own stories in the medical care that we get, in the medical care that our family and friends get. So I just want to start off by talking about what is advanced care planning. And this cartoon says we're on the same page, yet we can't seem to agree on anything. And the reason that I bring this up is to sort of let you know that every time I give this talk, I realize that people think advanced care planning is many different things. And nothing was made more sort of real to me than when I convened a very large Delphi panel of 50 proclaimed experts in advanced care planning from around the country and some international members to start thinking about research outcomes for advanced care planning. And I assumed, because everybody was an advanced care planning expert, that they would think that advanced care planning is the same thing, and they weren't. So we had to actually halt that whole study that we were doing to come back to figure out what a definition of advanced care planning is. So we're all on the same page for this talk. I will show you sort of the definition that was just published this year, which I can't believe I'm saying, in terms of a consensus definition for advanced care planning. And that is that advanced care planning is a process, not a one-time event, that supports adults at any age or stage of health in understanding and sharing their personal values, life goals, and preferences regarding future medical care. The goal of advanced care planning is to help ensure that people receive medical care that's consistent with their values, goals, and preferences during serious and chronic illness. Again, to start us off on the same page, but just to let people know sort of where sort of my passion is and where my work has been, this is sort of a conceptualization from Respecting Choices. And they often think of advanced care planning in terms of first steps, next steps, and last steps. And oftentimes this is thought of in terms of life course, but I also think about this in terms of readiness to engage. We all know those patients who have end-stage terminal cancer and they're just not ready to go there. So they might be in their first steps. And I would say that that is where sort of all of my research has been in. How can we pull advanced care planning upstream to normalize it in terms of somebody's life course? And how do we not freak people out who might be in the last stages of their life, but really in the first stages of their readiness? So that's a little bit of what I'm going to be talking about. So advanced care planning is hard. I don't think we need to go into sort of why it's hard, but I think as I've heard from many of these groups, people don't like to talk about death. It's very uncomfortable. People don't know how to start the conversation. And the question is, can we make it easier on ourselves, and can we make it easier on the patients and family members we talk to? So because this was an ethics lecture, I actually thought I would start by talking about health literacy and advanced care planning, because that's how I got interested in all of this in the first place, and then really focusing on making it easier. So considering it an alternative approach to advanced care planning and some of our easy-to-use patient-facing tools that are free to the public and you might be able to use with your own patients. So advanced directives in health literacy. So this cartoon says, you don't call this a legal document, do you? I can understand every word on it. And I have to say, way back in the day, way back when I was in medical school, I really became interested in the fact that most of the information we give out to people, informed consent, written at a postgraduate reading level, many people can't understand this. And this was the advanced directive that was being used at San Francisco General Hospital. I was on the San Francisco General Hospital Ethics Committee, and people were bemoaning the fact that many of our patients were ending up in the ICU unbefriended, and nobody knew what to do for them. They were on ventilators for months. And Doug White actually did a study showing that over 15% of ICU patients were unrepresented and had no information in their medical record. And they were sort of, standing around talking about, boy, I can't understand why we have such low rates of advanced care planning. The font on this form is about 8-point font, and there are really sort of arcane language in there, which I'll come back to. And then I really started thinking about this from the patient standpoint. When you think about advanced care planning, if it's done the way that we think it's supposed to maybe happen in the clinical context at least, the clinician initiates a conversation or gives materials. We think what the patient will ask questions, right? They identify their wishes. They discuss their wishes with the surrogate and the doctor. They understand all of the things that they want to do in the documents, and then they document it and the clinician places it in the medical record. And when you think about advanced care planning, all of these interim things have to be done by the patient. And these patient tasks are affected by literacy, language, and culture. And if we do not attend to that, sort of more than half of this equation is sort of going to have problems. So health literacy is a degree to which individuals have the capacity to obtain, but also process and understand basic health information and services needed to make appropriate health decisions. The mean or average reading level in the US is only at the 8th grade. And for the Medicaid and the elderly, as a geriatrician, my population, it's only at the 5th grade. So then we layer on top of that emotion. Somebody just got a diagnosis of cancer, or they're experiencing symptoms. And again, when we think about the ability to process information, this gets even worse. What about language considerations? 61 million people in the US, or about 20%, speak a language other than English at home. There are 40 million Spanish speakers and about 3 million Chinese speakers. And there really have been sort of a lack of linguistically appropriate materials. Cultural considerations. What about non-Western views on autonomy and decision-making? We find in our work that about 20% of people say that they're not going to make their own medical decisions, and they don't want to. So what do we do about that? What about perceived, racism and mistrust? I can tell you again from our studies, there are plenty of minority populations that basically say that they will never fill out advanced directive forms. So what do we do about that sort of patient population? And when we think about advanced directives, these are really high stakes. So checkbox responses, right, can have life and death consequences, especially if you don't understand them. So again, this is the advanced directive, and there's very arcane language, so this is one of my favorites. Your agent will have the right to make anatomical gifts, authorize an autopsy, and direct the disposition of your remains. So, like, what does that mean, right? So, and then a little, about POLST. So I can tell you that this was from one of my own clinic patients who came in and brought their POLST. This is a California POLST form, and they had marked that they didn't want resuscitation and they wanted selective treatment. And they came in, they were all proud of themselves, and they brought me the POLST form. And I asked the person, I said, well, what does this mean to you? And he says, I only want to be on machines for a few days. My family knows this. And I thought, no, they don't, and neither do your doctors. And I've been working a lot with Susan, who recently published a paper showing that in terms of this section, only about 50% of nursing home patients understood this section, and about 30% of people had discordant values. So, we've done sort of work showing sort of advanced directive confusion, and this was a quote from one of the surrogates that said, my mom passed away, and she signed the paper in the hospital, but it was totally wrong because she didn't really understand it. We had another one filled out, and that one said, do you want to be resuscitated? Do you want to be on a machine or not? And she said no, and then the questions were in conflict. One said yes, one said no. That really confused us. She got really frustrated. She didn't want to talk about it anymore. And she didn't, and she had a terrible end-of-life course that still to this day her children are living with. So for me, this is just not okay. And I would say that righteous indignation has been an incredibly powerful motivator sort of in my work, because this is not okay. Patients should understand the decisions they're making, especially if they're about life and death situations. So we spent a lot of time, sort of when I was on the ethics committee way back in the day, to create easy-to-read advanced directives. We were so proud of ourselves, and then the hospital came back and the risk manager said, well, unless you do a trial and show us that patients really want this form, we're not going to accept it. And that's how I started my research career, because I thought, well, I'll show you. And we did. So we showed that people, you can imagine, overwhelmingly preferred this easy-to-read form. The thing that was interesting to us is that this was really regardless of literacy or language. So people who even had higher level degrees, when you're dealing with serious, emotionally laden information, preferred the easy-to-read form. We doubled our completion rates from baseline, and we've given this form out for free, and it's available in multiple different languages. And I have to tell you, when we started doing this and the trial came out back in 2007, I thought I had solved the problem of advanced care planning. That all I really needed to do was to give people these easy-to-read forms, and we're done. Like, this is all great. So let's talk about what I learned, and I like to say, like, it's very important in research to be humble, because I have been schooled many times that what I thought was perfect and right was actually wrong. So let's talk about considering an alternative approach. So just as I had thought about the traditional objective of advanced care planning and approach, is to have patients make treatment decisions, CPR, mechanical ventilation, in advance of serious illness, an attempt to provide care consistent with their goals. And I would say advanced directive POLST forms, they're most often used. And clinicians and lawyers, we sort of like our checkbox. Are you DNR, DNI? Yes or no? Can we just fill out the form? And then we basically never have to have this conversation again. And advanced directives are helpful. I won't go into sort of all of the details, but it can help with communication. There's some reports in the New England Journal of Medicine that maybe you do get the care that you want in the last days of life, and that's great. I would say as a geriatrician, well, what about the last years of life? What about sort of demented patients who are living for 10 years, and there are many decisions that patients and their families are making over time? And I think the problems with only an advanced directive is that they're not available when needed, and I would say that the POLST in the EMR is sort of starting to fix that problem, which is great, but just an advance directive without a discussion and without sort of broader thought has been shown in studies not to improve knowledge of patients' preferences, doesn't always affect care and cost at the end of life, doesn't prevent surrogate stress and conflict in the absence of sort of ongoing conversations. And our advance directives are enough. And I will tell you, this is a very heartbreaking sort of quote from one of our surrogates that said, "We got the DNR, do not resuscitate in writing, but in making the decisions, which there were many, that was just one. Because the first decision was to put him in a nursing home. We were married 30 years and I could no longer take care of him. Then the second decision was whether to put him on a feeding tube because he had stopped eating and I wasn't ready to let him go." And I think we sort of know intuitively that no form or checkbox will ever eliminate the uncertainty and the complexity of the human condition, though I feel like we, and myself, I still find myself trying to do that. But you can't cram somebody's story and somebody's life into a checkbox. And so the way that I've been thinking about this is that people need better preparation for all of these different types of decisions that might be coming sort of their way. So when you're thinking about first steps, again, what I'm interested in, what do you discuss? What if you're talking to a terminal patient who isn't ready to have that conversation? What about non-terminal patients that have chronic illness? Am I supposed to be talking about life-sustaining treatments? Something different than that? And again, how do we prepare people for these discussions and decisions? So I think some of the problems with treatment decisions way in advance is that it's sort of flawed because of some things related to prediction, adaptation, and extrapolation. And I will say, because I work very closely with Susan and Kathleen and other people in this room, that again, I'm talking about first steps maybe farther away from the end of somebody's life. But I think the problems with prediction are that people often can't predict. We've known from sociologic studies what they're going to have for dinner or buy at the store 30 minutes ahead of time, much less the exact medical care that they want in every context a week, month, or years from now. And I think that the issue is that these predictions do not reflect somebody's current emotional, medical, or social context, and people's preferences change all the time. So I actually was just talking with my palliative care colleagues because I have a patient who I've been seeing for the last year who had a stroke, went to the nursing home. This is a very highly educated person who is incredibly unhappy. We've done all of these things to try to make him happy, and he's so unhappy that he's been talking to me for 6 months and has set a date for voluntarily stopping eating and drinking. I've had multiple conversations with his family. He begged me, I just saw him a week ago, he begged me and his family that if he were to get pneumonia or if he were to get an infection, to not transfer him from the nursing home, to please let him die. And he was just admitted for pneumonia and asked for antibiotics. People change their mind, and that's okay, but we need to let people know what their options are. So what about uncertainty and hypothetical scenarios? I'll just tell you, when we've done studies, giving them easy to read advance directives and asking, as we often do, if you were in this situation. 50% of diverse older adults who reported a treatment preference on an advance directive based on a hypothetical scenario were uncertain about their decision. Yet we write it in stone, and then we think that this is sort of the end of that conversation. And uncertainty, again, associated with things like limited literacy, minority status, and even poor health status. I don't think people know how they're going to feel until they're faced with the situation. They may have all kinds of theoretical ideas or something they read in Dear Abby, but when the time comes, you may be very surprised at your own reaction to something. I mean, it's not as easy as black and white. There are many gray areas. What about adaptation? So people will say that they can't envision being able to cope with a disability, but then studies show that they can. So people will say, if I were in a nursing home, or if I were bedbound, if I had an amputation, forget it, pull the plug. But then that happens to them, and again, study after study shows that we as humans can be incredibly adaptable. And sometimes people adapt, and sometimes they don't. And then extrapolation. So we make these decisions on a POLST or an advance directive, but then what about decisions about less invasive treatments? Because you said you were DNR, DNI, does that mean that you don't have surgery that might be able to actually make you feel better or live longer? What about chemotherapy? What about nursing home placement? And sometimes wishes need to change in the light of unforeseen circumstances. So nothing's written in stone. You can't know to say, well, this is what I want, do not resuscitate, but then the situation at hand can be totally different to where you do or don't have a chance of them resuscitating you. So now what? So people say, well, why don't you just designate a surrogate decision maker and then you can just sort of be done with it. And again, I would say in my line of work and studies show that surrogates often don't know that they were chosen because nobody's ever had a conversation with them. Knowledge of preferences, again, no better than chance in the absence of a conversation. Stress, anxiety, and studies are showing that surrogates walk away with PTSD. So they walk away not trusting the medical environment and having their own negative thoughts about advanced care planning and things like that. And then using own hopes, desires, and needs. And this is where I like to tell a story about my grandparents. So this is them on their wedding day back in the early 1940s. And my grandfather was a veteran, and like many of the veterans that I take care of in my geriatrics clinic, had, I think, pretty much every organ system down, had 20 medical problems, was very frail in his last year of life. And the day after Christmas, he fell and he broke his hip, and he was hospitalized. They pinned his hip, and he was in the hospital for 3 days, and then they transferred him to the nursing home. He's a diabetic. He had compression stocking on his legs. They had immobilized him, and nobody thought to check his heels. And on the 4th day, when his nursing home doctor came to evaluate him, he had stage 4 decubitus ulcer to bone in both of his heels. He never walked again, and he spent the next 6 months of his life going back and forth for surgical debridement, for infections, for kidney failure, back and forth to the hospital. This is when I was a geriatrics fellow, and nobody had had a goals of care conversation with him. And I didn't want to have to be the one to do it, but I thought somebody had to do it, and so I did. And I had this very long conversation with my grandparents, and my grandfather was very clear. He said, I'm tired, I'm not afraid of dying, please, no breathing tubes, no chest compressions, no shocks, no pushing on my chest. I'm really done, please just let me go. And my grandmother was tearful, and I turned to her and I said, did you hear what Grandpa said? And she said, yes. And I said, well, what are you going to tell the doctors to do if, Grandpa stops breathing or his heart stops beating? And she said, well, of course, I'd tell the doctors to do everything possible to keep my husband alive. And I was so upset, and I thought, did we not just have this wonderful, I was such a great communicator for 45 minutes, and I'll come back sort of to this story. So now what? So why do anything in advance? And I have to tell you, we were talking this morning, there's some people in our field that think that maybe we shouldn't do anything in advance, but I'm not one of those people. And I think the reason is that basically we as clinicians, we cannot make recommendations or guide people in decision-making without understanding patients' values and goals. Unfortunately for the patient, that's highly individual, and it has to come from them or their family members, right? It can only be provided for them. And again, it's too bad for them because that is a high bar. That is a lot to ask of someone. And without preparation, patients and surrogates may not be able to communicate their values and goals effectively, especially if they've never thought about this before. They end up in the emergency room, lots of emotion, lots of stress. How many times do these patients see people they've never met before in the hospital or the emergency room? They have no relationship, and now all of a sudden they're supposed to speak up for themselves and say what they want in that situation. So we sort of thought about a paradigm shift. So this says, I'm afraid you've had a paradigm shift. And we really did a lot of work to really think about how we can redefine the planning and advanced care planning. I can't believe that this paper was written 7 years ago now, so this was back in 2010, but it really has been sort of the foundation of some of the patient materials. And this really shifts the focus from not only talking about life-sustaining treatments, which are incredibly important, but also thinking about how can we prepare people for communication and decision-making, which might be many decisions in communication that they have over time. So preparing sort of for in-the-moment decision-making as well as future decision-making, again, shifts the focus from only asking people about treatment decisions and seeks to prepare people with skills to identify what's most important to them, which might be evolving. How do you actually communicate with surrogates and providers in a way that makes sense? And how do you take what you've just identified to make informed medical decisions over time. And when you think about it, an advanced directive or a POLST really should be a marker of full preparation and reflect these discussions over time. So how best to prepare? So I will just say that, when we think about the ways that we have these conversations and when we get back to thinking about these check boxes, what matters most to people is the outcome, right? So I show this sort of cart before the horse. So it's not the treatment, but it's the outcome of treatment. So, it's not sort of intubation or CPR, what I call the cart, but how their life will be after treatment. And I feel like as clinicians, we always start with the cart. We always start with, do you want CPR? We don't start with, who are you as a person? What brings your life value and meaning? What are the things that you want for your life? And will the treatment that I am providing going to get you that outcome? Are we reviving him, sticking the tube in so that he can suffer more? I guess it goes back to what happens if you revive him. Is he going through that whole process again? It's the end result. If I go through all of this, how weak will I be? How is that going to make me, will I be able to get up myself out of bed and take a bath? What will happen to me? This is what people care about, what their life's going to be like. And I think sometimes what we've learned from our work is that stories can really help frame values about outcomes. So prior stories about themselves or family and friends can really help. So we, back in the day, did a study about the media event around Terri Schiavo. And if people are too young to remember that, go to hell. But also, she was a woman who was in a persistent vegetative state all over the news. And there was a Supreme Court case about taking out her feeding tube. But what was interesting is this whole thing was swirling around when we were doing our randomized control trial for Advanced Directive. And we thought, well, first of all, we need to control for this. And secondly, what's going on? And 92% of English and Spanish-speaking, diverse, vulnerable older adults at a county hospital had heard of the Terri Schiavo case. And due to her case, 61% had clarified their own values for care. So you can see that of those 66% talked to family and only 8% talked to their doctors. But stories, again, getting back to stories, can help people sort of frame what their own values and goals are. And I think reflecting on changes in their own story, in their own context. So reflecting on whether changing or adapting to serious illness, like my patient who just got admitted to the hospital, maybe changing or adapting to his illness. And it helps people better predict their preferences. So as the disease trajectory progresses, you can get more specific. So when you were in the hospital with heart failure, when you were in the ICU and intubated, and when I have a conversation with this patient, you just got admitted and told me you didn't want antibiotics, but then you got them. Let's talk about that. How did that go for you? Would that be worth it to you to do that again? So surrogates need preparation. So I like to say that basically a half to 3/4 of you in this room will be unable to participate in some or all of your own decisions at the end of life, and somebody might need to do it for you. But we know that surrogates report that they're unprepared to make these decisions. They were never asked. They don't know their role, and they see the process as highly stressful. So the only thing I managed to talk to my father about was if anything should happen and his heart should stop. That was the extent of how much I knew what his wishes were. The other stuff we were guessing at is to know whether he would want to be home or in a hospice. And again, you can't talk about every single possible potential thing that may happen and decision because you just don't know. But again, I think focusing on the outcomes and sort of trying to create plans that meet that can help with some of these problems. And then I just want to talk a little bit about surrogate leeway because we've wrapped a lot of this into our tools. So surrogates may need to make decisions that conflict with patients' prior reported preferences. So I don't know if this has happened to people, but because I take care of older adults, I can't tell you how many times I have someone who said that they wanted to die at home and they can no longer make decisions for themselves, and the only person that can care for them is their 95-year-old, 90-pound wife who can't do that in a safe environment. And then she is crushed because she feels that she is handcuffed to this decision that was made 10 years before? What about being asked to withdraw care because somebody may benefit from transient treatment? And so surrogate burden can be eased by giving them permission to consider factors other than prior wishes during in-the-moment decision-making, again, because context may change. This is called leeway. And there's a study that was done way back in the 90s among patients who were on hemodialysis asking about leeway. And 39% said no leeway, but over 60% said, yeah, it's okay for my doctor or my decision maker to have some form of leeway. And again, this is an ethics lecture, so I will say ethically, if you have a conversation ahead of time, this is still an extension of somebody's autonomy because you've had the ability to talk about it. And sitting on the ethics committee at our VA hospital, I can tell you, like, boy, if leeway had been talked about ahead of time, a lot of sort of the ethics consults that come through probably could have been avoided. So, and this gets back to my grandparents. So you remember my grandfather said, I don't want anything. My grandmother said, full court press, do everything possible. And I freaked out. And I thought, well, my grandmother shouldn't be this, my grandfather's decision maker. And I turned to my grandfather and I said, well, how do you feel about this and what should we do? And he said, I'm ready to go. But if it helps your grandmother to feel that she did everything possible for me, even if it's because she doesn't want me to go, that is okay. Sorry, I've read this 100 times and I always tear up. She's the one who has to go on living with her decision. If this is what she wants, then this is what I want because I love her. And I didn't understand it and I was very upset at the time. But my grandfather coded in the nursing home. They coded him for 15 minutes. He never regained consciousness. And to this day, my grandmother feels like she made the best decision for him possible. She trusts the medical system in a way that she didn't before because she felt like they followed their wishes. And she's DNR, DNI for whatever that's worth, and have been able to have conversations with her, about this. So I think for clinicians, and I'm only going to take a few minutes to talk about this because I'm going to refer you to our paper. But I think for clinicians, one of the things that I often find is that people get very overwhelmed because they think, I have to talk about advanced care planning, and it's this huge sort of box, and I don't know how to unpackage it. And, I think whether you're an inpatient palliative care physician or just like me, you're both that and an outpatient primary care physician, I think there are ways that this can be chunked down for clinicians to make it easier for you, but also to not sort of cognitively overburden your patients so that they can slowly start thinking about this. So just like the information I sort of showed you, helping people choose a surrogate and make sure that the surrogate has been asked and wrapped into these discussions, clarify values about the outcome of treatment, so how their life will be and not just about CPR, reassess over time for changes in their wishes, and establishing leeway in surrogate decision-making. So again, I'm just going to talk about this briefly, and again, I'll refer you to this paper because we really tried to have like the words you could say to make this very easy. But in terms of surrogates and thinking about stories, is there anyone you trust to make medical decisions for you? I would say that that's usually the end of that conversation. But I think it's important we go a step further. Does this person know you chose him or her for this role? What have you talked about? And I have to say, sometimes this is the only question I need to ask, and I get all the information that I need to know. Or somebody thinks to themselves, well, I have a surrogate, so I'm good. Oh, wait a minute, I didn't ask them. What do you mean we've never had a conversation about this? Step 2, maybe the next time you see someone, you start the conversation with the surrogate. Maybe the next time, how do you define good quality of life? Coming back to the stories, have you seen someone on TV or had someone close to you who had serious illness? What went well, what did not go well, and why? And if you were in that situation or in that situation again, what would you hope for? And I'll give you sort of an example. I had a patient in my clinic who had prostate cancer, and it had metastasized. And even before that, I had been trying to talk to this guy for, and I'm not kidding when I say this, 5 years about advanced care planning. He would not talk to me about it. I had given him maybe 20 of our easy-to-read advanced directives. I had set him up with a social work appointment. I had a dedicated appointment set up with me someone who does advanced care planning research, he would not do it. And then his brother died in the ICU of complications from prostate cancer. And and he came in and he told me the story, and I just said, well, can you tell me about that? What was that like? What was that other situation like for you? And he told me everything that I needed to know about his goals of care. He couldn't say it for himself, but he could tell me about a story in his own life, and that's been a very powerful tool. Something called a spectrum question, which I will sort of I'll tell you about it because I've found this to be incredibly helpful, and we've actually wrapped this into our Prepare tool. Sort of this idea of normalizing that people can be on one of sort of different spectrums, and I will use my hands and sort of say, some people are on one side of the spectrum and say that life would always be worth living, basically no matter what. And some people are on the other end of the spectrum and would say that maybe some health experiences or situations may make life not worth living. Where are you on this spectrum? And I have to say it's a rare person who can't point somewhere on this spectrum. And if they point here, that life's always worth living no matter what, we can have a conversation about it. But again, some of these things become less ambiguous, and it's easier for people to answer that question than, do you want CPR or not? And then there's some things here which I'll let you read in the paper about leeway. So, and then I think again, our job really then is that we're translators, right? So based on what you told me about what brings your life meaning, about how you felt about your loved one's experiences, about how you felt about your last hospitalization, it sounds as though X might be something that you would or would not want for yourself. Is that correct? And this, again, I think what often happens, and I see this in the inpatient setting all the time, we say, do you want CPR? Do you want mechanical ventilation? And if we think it makes sense and they say yes, we're like, okay, great, I'm just going to write full code, let's just move on. And then when somebody has terminal illness and it's like, oh, you said full code? Well, wrong answer. Okay, let's get palliative care involved so they could make somebody be DNR, DNI. Do you see what I'm saying? We start again with a cart, and we should be starting with the horse about what are the things that bring people life meaning, and then helping people translate that to the actual medical care and checking with them to see if that makes sense. Okay, so now I'm going to move on to sort of how we've translated all of that into some easy to use patient-facing materials, and again, letting you guys know about these so you can think about ways that you might be able to use them with your own patients. So I think if you had to make tough decisions for yourself or others, right, there's probably a lot of things you would hope for, but you'd hope that you'd have a clinician who has time and training to communicate clearly and compassionately. And there are many people in this room that are working on those things, but I think you'd also hope that you have a framework to fall back on so that you can identify what's most important to you, that you know how you can communicate, and you know how to make informed decisions. Because again, when those things happen, I think, as you know, many things just go outside of your mind. And I think the major thing that I see, especially since I work with disenfranchised, diverse, vulnerable older adults, is that people are often not empowered in these power differential relationships when they're stressed and they're sick to speak up for themselves, and their surrogates are not empowered. So how can we fix that? And I think, again, coming back to some of the things in the work that we've done in terms of that missing puzzle piece, is how can we prepare people with skills to identify, again, what is most important to them and how they want to live? How can we help them talk to their family and friends, their medical providers, make informed decisions, and get the care that is right for them? And I'll just say that, sitting in my office and telling someone to go and choose a medical decision maker and talk to somebody about it, that is, again, a very high bar. How are people supposed to do that? So that's why we came up with this Prepare website, which is an online advanced care planning tool that's available in English and Spanish. And in creating Prepare, I like to use this cartoon that says, no, what I said was we need more stakeholders, not snakeholders. And I feel like I may be the only person that finds this cartoon funny. But I've had, I think throughout the whole process of Prepare, it's really been designed with and for the community and with and for stakeholders and our target population, which takes longer, it is definitely harder, but But again, we've learned so much and changed so much based on direct feedback. So why a patient-facing website, people will ask me. If you're interested in disenfranchised older adults, like, why would you choose a website? Well, I think for clinicians, we know that there's lack of time and resources. So right now, as we're trying to fix the healthcare system, we're still in a situation where many primary care clinicians don't have time to have these conversations. It's easier for dissemination, and it really allows us to tell a story because we can show videos and other video stories. Also, there have been Pew reports basically showing this sort of exponential increase in the use of the internet and older adults specifically on their phone. So when Prepare was launched, my mom watched it on her phone. She might not use the computer, but she can access the internet. And so we thought, well, that's why we went with the website. And I think we know from Angela Volanda's and other people's work that, again, these video images and stories can be incredibly powerful. So I'm not going to bore you with the details, but again, in terms of Prepare, we really focus this on social cognitive theory, the health belief model, theory plan behavior, stages of change, and wrap that into the actual construction of the materials to help empower people and get them engaged. And we had an expert panel, again, with experts in health literacy, geriatrics, behavior change. I've been reading you some quotes from our 13 focus groups from patients and surrogates. Extensive cognitive one-on-one interviews again. And then really, I think getting back to sort of some of the behavior change models, thinking about videos that don't just tell people they should do something, they actually show people how to do something by modeling that behavior. So it's not just the what, it's the how. You know, again, with my health literacy work, we wanted to make sure it was easy to understand. So it's at a 5th grade reading level. There's voiceovers for individuals who may be illiterate or have difficulty reading, closed captioning for people who have difficulty hearing. And we went out of our way in our incredible shoestring budget to sort of balance the content of the videos for race, ethnicity, and gender, people who wanted aggressive treatment versus comfort care, again, surrogate availability. So 15% of our patients will report that they don't have one person to choose as a surrogate decision maker. And if step 1 of my program, which it is to choose a medical decision maker, you got to think about having content that's going to get the 15% that don't. Decision-making preferences, as we talked about 20% will report they don't want to make their own decisions, and how do you have tailored content for that? So this is, again, an interactive multimedia website. There's 5 steps. Again, choose a decision maker, decide what matters most in life. So it's the outcomes of treatment, flexibility for your decision maker, and then videos that show people how do you now that you've decided these things, how do you have these discussions? How do you tell your doctor about them? How do you tell your family about them? And then importantly, how do you ask doctors the right questions so you can get the medical care that's right for you? So I'm not going to show these videos, but just to say, you know, that they're very much, again, focused on how to do it. So how to ask somebody to be a decision maker. Here are the words you could use if you want to do that. How could you overcome barriers if that's a hard thing for you? How do you tell others about your wishes? How do you ask doctors the right questions? As people go through, they can answer questions about their values and goals, and this gets printed out as a summary of my wishes. Again, for those people who will never complete an advanced directive form, this is something that allows a template for people to have discussions with their doctors or their family members. The medical provider stakeholders that we heard from said that they wanted the form that says, for the medical provider, that tells them where this came from Prepare website and what are all the options. And then for people who are ready to fill out an advanced directive, it, again, translate those values into actually completing a form. So we had done some pilot testing in low-income senior centers, and in this pilot, the mean age was 70 years, and 92% had never used a computer before. So this was a pre to post study looking at engagement in any advanced care planning, and that increased from 40% to 100%. And I think what we were most excited about is that this very computer-naive older adult group rated using Prepare on a 9 to 10 scale. And I think, again, that goes back to us creating this stuff with and for older adults to make sure it was easy to use. We were able to get additional research grants, and we've had 3 RCTs going on with Prepare. We've been able to translate it again into Spanish. We've started translation in Chinese, but are hoping for additional funding to finalize the videos. But I'm just going to tell you about the trial results that came out for our VA trial in May of this last year. So this was a patient-facing randomized trial, and what I mean by that is when you think about advanced care planning, it really is a systems-level problem, and you can focus it on clinician and facilitator communication. You can focus it again on more system-level things such as workflow and EMR, and all of those things are needed, or you could just focus it on the patient, and that's what we did. So at the VA study, we only gave patients materials. We did nothing for the clinician. We did no training. We did no education. We did no change to the healthcare system or the EMR. So this was a randomized trial, again, patient-facing only. So we gave people an easy-to-read advanced directive. We gave people the easy-to-read advanced directive plus Prepare. And again, we wanted to know, like in resource-poor environments, if I work at a county hospital and I know that they will never be able to afford a facilitator, and I know that their EMR is broken, how much bang for our buck could we get if we just gave it to the patient and just see what happens? Does this stuff end up back in the medical record? And so we found at RVA that 6 months before baseline, the advanced care planning documentation rate was actually less than 1%. By giving people the easy-to-read advanced directive, 25% of our population filled out an advanced directive and it actually got into the medical record. And by adding on Prepare, that increased to 35%. When we looked at other sort of things, when we actually talked to patients, so not just looking in their medical record, when we looked at things like self-efficacy and readiness, their behavior change, over time, 1 week, 3 months, and 6 months, there was definitely an increase between Prepare and the advanced directive only. And when we asked about advanced directive specific actions, also higher for Prepare than the advanced directive. So I think now we're really trying to get this information out to the community, and that's one of the things that I wanted to tell you about as well. So sort of cool new stuff. So as these things happen, you have to kind of wait for your updates until you get more grant funding. So we got some more foundation grant support, and we're able to launch sort of a new streamlined version of Prepare. So some of the feedback that we received was, well, I come to the Prepare website and I don't know what it's about. Or I really like it, but it's just a little too long. Can you help, make it sort of more streamlined? And that's sort of what we did. So we created this little B-roll video that takes about 1.5 minutes that kind of tells people what the website's about. And we have these free resources on the website. So there's the pamphlet, which I like to call the Cliff Notes of the Prepare website, that people can print out and hand out to people. I'll tell you a little bit more about our easy-to-read advanced directives, and then there's the Prepare questions. So our advanced directives got a facelift. So again, these forms have been out in the community for 13 years. They were made with free clip art that we could get off the internet, and created, sort of in, on my nights and weekends. And we were able to sort of, again, update them a little bit. And then what's really exciting to us is that we got funding from the Gordon and Betty Moore Foundation to finally do what I've been wanting to do for 13 years, which is to update these easy-to-read advanced directives for all states in English and Spanish. And so we've started to roll out, our first set of states just went live about 2 weeks ago. We are working on an Indiana form. I will say that your laws are a little harder than some other laws, so they're coming out sort of in the new year. But we're really excited about that, and all of these will be available for free on the website. And then I wanted to tell you about Prepare as a movie. So we started creating a movie version of Prepare because we realized that some of our illiterate patients, they're not going to be able to click through the website, and maybe they just need to watch sort of the movie. But what we didn't sort of anticipate is that people started using them in libraries, churches, and senior centers to be able to put on advanced care planning events. And so we have just revamped our Prepare movies. With the launch of the new movie will hopefully be by the end of this month. And our toolkits that we've created so that basically you don't need any training at all, that anyone out in the public could put on this event because all of the advanced care planning information is in the Prepare website. So we actually did some testing. So we did some testing in senior centers, and one of My mentees did this in a couple of group medical visits. And I'll just tell you really briefly, in senior centers, we found that, people either agreed or strongly agreed that the videos were really easy to understand, that they were ready to answer questions about their preferences for medical care, and that they would recommend the session to other people. In terms of the group medical visits, and this just got accepted for publication, this was a small study, only 22 people in 2 different groups, but we looked at pre to post from 1 week later, and surrogate designation increased from 48 to 85%, and advanced directive completion increased from 9 to 24%, and again, in terms of ease of use of all of the materials, it was rated an 8.5 on a 10-point scale. So I'm happy to talk to other people about this. We're doing some new population health studies, a PCORI grant that we just got in terms of how can we automate sort of the dissemination of some of these materials directly to patients. And again, to see sort of what happens if this is just patient facing. And again, like I said, we're trying to get Prepare into Chinese. It has been on my radar screen for years. Lexi knows this, Prepare for Surrogates. And we've been talking to our institution about how we can integrate this sort of into the EMR and MyChart. So with that, I'll say thank you. And it looks like we have about 6 minutes or so for questions. So thank you.
There you go, sure.
Hi, I'm Lucia Bosch. I'm with the School of Nursing. I had a student make a recommendation which was sort of novel, and I want to know what you think about it. It's a Joint Commission requirement that when patients are admitted to hospitals, they're asked, do they have an advance directive, which usually freaks them out. What if we ask people on their way out when they're leaving the hospital? Based on what you know about Prepare and everything you've done, what do you think about that, and sort of shift that question to a different point where maybe they're more ready to hear it?
Yeah, so I think, I was talking with the palliative care group yesterday about this idea about normalizing advanced care planning, normalizing these forms. And the thing is that we wait until somebody's in a crisis and are being admitted to the hospital to sort of bring them up. But if they sort of became just standard of what we do in primary care, standard of what we do for the first visit when you go to oncology, standard what you do, when you're in the emergency room or you do get admitted to the hospital or when you leave the hospital. I think that there are many entry points to sort of do this. I would say when somebody is getting admitted, the conversation is probably a better place to start instead of handing somebody a form, because that regulation has been just so somebody can check off a box and say that they did it, right? It's not that they did it and that was combined with a, lovely, important conversation. So I think, to be honest, what I start doing with my patients in primary care, and as I was always saying, I think to the group yesterday, is that I talk to them about advanced care planning at every single visit. Maybe I only talk to them for 1 minute, but I say we filled out an advanced directive and you said this, do you still feel the same way? And by the way, if you go to the emergency room, people are going to ask you this question because it's really important. And so this idea that it's in people's consciousness and your entry into the hospital isn't the first time that you're hearing about this. But I would say that I do have colleagues that are studying, actually looking at giving people information when they leave the hospital because they just had this thing happen to them. And it's a perfect time for people to think about wow, how did that go for me? What are the outcomes that are important to me? Did I change my mind about what I thought was important? So that's a long-winded answer to your question, but I think it's a good time to do it.
My name is Paul Helft. I'm an oncologist, and I direct the Fairbanks Center for Medical Ethics. And that was luminous, the best presentation I've ever heard on this particular topic. I just wonder, I have sort of a meta question about this type of intervention, since people have been doing, this sort of exists in my mind in the universe of decision aid type interventions. And there's been very little evidence after 30 or 40 years of research that decision aids actually impact patient care at the ground level. So the type 3 translation problem. And I just wondered what your thoughts are and the evidence are that I mean, I think I have great admiration for all of this work, but I just wondered how you think you'll overcome those sort of global problems around decision aids and other kinds of technical intervention.
Yeah, I think that is a really great question, and I actually have to say that that is where our field needs to go, because the studies sort of looking at the downstream outcomes, they haven't been that robust, to be frankly honest. And I actually think that we do need more hard evidence showing that. You know, I will say, again, because I'm a palliative care physician and a geriatrician, experientially over the last 20 years of my career, I still feel like it's important, even though I don't have evidence showing me these hard things. And I think one of the things about advanced care planning that has been difficult is it's been hard to define what the outcomes should be. So we've been working a lot. It's a sort of a longer, there's like a whole talk I could give about outcomes sort of advanced care planning, because what does that mean? I would say that there at the VA, there's something called the Bereaved Family Survey. I think I was talking to Shelley about that sort of yesterday. I don't know if people have heard about that. But for older veteran or any veteran actually who dies, started out just being in a VA facility, but now sort of anywhere. So even if you're out in the community, they will attempt to call up veterans' families within 3 months of that death and ask people, did they get the care that they wanted? How did that go? With the idea that it's not just about utilization, it's not just about hospitalization, but it's literally what was that experience like, and was it high quality? And some of the studies have been showing from the VA that if you do advanced care planning, those Bereaved Family Survey scores are much higher. So I think we're headed in that direction, but we've definitely got a ways to go. All right, thank you.